Hello everyone, my name is Rachel Moses and I'm a consultant respiratory physiotherapist and I'm currently in a chief AHP role. And I'm delighted today to be joined by some friends and colleagues to talk all things COVID, respiratory physiotherapy managers and leaders. So I'm just going to start by introducing everyone. So in my bottom right hand screen is Emma Swingwood, who is respiratory pathway lead at University Hospitals Bristol and Weston. She's also the physio lead at Nightingale, Bristol, and chair of the ACPRC. To my left is Eleanor Douglas, who is lecturer, practitioner, physiotherapist at the University of Nottingham and Nottingham University Hospitals, and she's also chair of the Respiratory Leaders and Physiotherapy Group. And last but by no means least is Eve Corner, who was a lecturer and research physiotherapist at Brunel University and Imperial College Healthcare Trust. So I'm delighted to welcome you all today, and I do want to start by the usual disclaimer of saying these people have come in their own time to talk about their lived experiences so far of the pandemic. By no means what we're saying is gold standard or is the only way you can do this. This is just what we have seen in our practice, and we wanted to share that in a very real-time fashion. Please take everything you hear with a little bit of pinch of salt, and that this is just what we found. So I'm going to kick off by talking about education. And I sat in this room nearly 2 months ago to the day almost, and I'd done a series of podcasts and interviews and wrote some documents about how we can prepare for this pandemic. And I know a lot of my colleagues also did. And we're now 2 months in. We're learning all the time from our colleagues in other countries about how this pandemic has hit hospitals. And we're now in a better place to know actually how we've managed this crisis. And one thing we have now that we certainly didn't have back then is some amazing online educational platforms. And one of them, if I come across to you, Eve, is the COVID ICU remote course that you and your team developed. And I remember you texting one weekend and saying, oh, I've had this idea to bring this educational platform, and what do you think? And obviously with the skills that you and your team have, it was a bit of a no-brainer, but the speed in which you pulled this all around was just incredible. So do you want to start by telling us a little bit about your education resource?
Yeah, so when the COVID pandemic started, I kind of tried to think about my best role within the whole thing. I'm a critical care physio by background, run a critical care masters and run the critical care modules for the undergrads. So I got online to the Northwest London Critical Care Network meeting and discussed what our role at Brunel might be in terms of supporting education. One of the things that was happening was that because everyone was having to rapidly train critical care, non-critical care staff with critical care skills and knowledge, this was being done locally at a lot of the hospitals, and the education nurses, for example, were having to train up people over 2-3 days, and that took them out of the frontline workforce, and it meant everyone was having to be in a room together to have this training, so they couldn't socially distance. And so it occurred to us that maybe there was another way of helping to address at least the knowledge aspect, not necessarily the skills aspect, in terms of critical care management of the critical care patient. A group called CLEAR, which are part of a company called 33N and Health Education England, had a similar idea. So we got in touch and basically decided to develop a platform that enabled us to use protected staff, so staff that might be pregnant or have a chronic health condition, for example, who weren't able to work frontline, to help to deliver education to non-specialist workforce in critical care. We use a platform called Blackboard, which is basically has pre-recorded lectures and interactive tutorials. So people sign up in the morning and complete a series of lectures, and after each lecture there's a break-off tutorial room, and so specialist staff will then deliver those tutorials in an interactive way, so the group can discuss issues, they can ask questions, and we were able to separate the groups out into different professions. So we have physio ones, nursing ones, and medical training as well. And we were able to separate them out into kind of different levels of experience as well. So people that had more experience in critical care would be in one tutorial group, for example. And what that then enabled us to do is offload the frontline clinicians that were having to deliver that knowledge aspect of training to work clinically. It also, I think it was really important in that it's given a lot of the protected clinicians, it's made them feel like they've had, I think some of them were a bit frustrated that they couldn't work clinically and a bit felt like they weren't able to do their part. And I think that it made them feel a lot better about it because they were able to contribute to the pandemic in a productive way without putting themselves at risk on the front line. So we rolled out the initial training, which was, we did it within about 4 days between the idea and the kind of content development. And we piloted it at 5 hospitals. And then we're now somewhere in the region of about 1,100 people have been through the course. At the moment, there's been a dip in the number of people attending the acute course as the pandemic kind of slows down. However, should it peak again, we're continuing to run that acute course. We've also developed a rehab course, which is gaining momentum, which is addressing the rehab aspects of COVID in a multidisciplinary way. So yeah, it's been quite a successful, we hope anyway, been quite a successful and useful way of trying to give people at least some understanding of critical care. So when they go into that unit, they're not overwhelmed by because it is quite an overwhelming place to walk into an ICU if you're not used to it. But the feedback that we've had from people working in hospitals is that it was a really useful course to do. So.
No, definitely, Eve. It's for anyone that's done the course, it's getting exceptional feedback, the speed in which you pulled it around. And like you said, identifying a workforce that were available and could teach and giving people the permission to teach was really powerful. And we've seen this, and I know me and Eleanor spoke a little bit about how we use our workforce that are either pregnant or vulnerable or shielded. And how we can use skills in a remote fashion and working in ways we've never worked before. So, Eve, that's really just set the scene about how, from a theory and a knowledge base, we've tried to use our skills as respiratory physios to help educate and enhance the workforce that we already have. But Eleanor, you've got some great experience about how we've had to manage a workforce that didn't exist. So it's no surprise to anyone that we're not resourced to the level we should be in intensive care. We've been trying to gain proper funding for pathways for people who are critically unwell well before this pandemic and not being entirely successful. So where did we find this kind of workforce, and what training and skills did you do in your hospital?
Okay, so in Nottingham, we initially sat down with our managers and we had a list of every physio working across the trust, and then we identified where they would be working during the pandemic. So whether they were going to be redeployed and pulled back into sort of critical care ICU work, or whether they were going to be working on the wards, our respiratory wards. So we looked at the group that were normally in sort of MSK, ortho teams. So some of them could be quickly refreshed with their on-call, they were already on our on-call and weekend rotas. And then there are also a group who need refreshing in some of the sort of respiratory skills, revisiting sort of assessment and management of respiratory skills and when to refer into the respiratory team. So for that group, people who normally worked in sort of outpatients and orthopedics and maybe hadn't done specific respiratory physio for a while, we refreshed their skills. So, what we knew so far about COVID patients and how they presented, respiratory wise. So we revisited skills with them around oxygen therapy, assessment and some basic management skills, and when to refer those patients back to the, to the respiratory team if they felt they needed sort of escalating. So this was face-to-face teaching that we did in a socially distant manner. And then we brought redeployed staff working who were already on our weekend and on-call rotas, who may have recently come off the rota or were still working on the rota regularly. So we had some MSK specialists, some orthopaedic specialists who could quickly be reskilled in some of the things that we were needing to revisit with them, like use of adjuncts, and particularly in the critical care area, where we were also needing to have education on the different ventilators we were going to be using, proning, some of those skills that just needed a quick refresh because they already had recently been working in critical care areas. So there was like a 3-tiered workforce really. Those who could work on wards with refreshed respiratory skills and knowing when they needed to refer to a more respiratory specialist. Those who we could pull back in, who already had skills at weekends and on calls, who needed some refreshing about some of the things that we were, particularly sort of equipment and new equipment we were going to be using. And then we had our respiratory workforce who did a lot of that training.
That's love. I really like the way you have you've described that, because there's been a lot of talk about upskilling staff, and we're very mindful that, like you said, there is a group of people who have the skills, they just were hidden away in a little box because they moved into maybe an outpatient setting, and you just needed to open the box and get those skills back. And then there's
the way that they all just stepped up was amazing. They really wanted to help, they really wanted to use any skills that they had that would be suitable for managing COVID patients and managing the situation. So we were overwhelmed with their help and their ability to and their the fact that they were just happy to come and receive this training and do whatever they could to help the respiratory teams.
Absolutely. And Emma, I'm going to move across to you, because you have some experiences of how you actually use this in practice within your trust. You manage a huge team, and you had very specific people who were already very, very senior respiratory physiotherapists. You had people who had refresher training, and then you had this workforce that maybe had just become available because their normal activity no longer took place in the hospital. So do you want us to tell us a little bit about how you use these staff and and what your experiences are?
Yeah, so we have we start with a blank piece of paper, which is always useful, and used almost categorise all of our occupational therapy and physiotherapy staff into 3 main groups. So first of all, one would be people who are capable and very competent at working on critical care, or could have some skills refreshed to work in that area. Another group would be those with general, so non-ITU respiratory skills, and then some with key rehab skills. So there's absolutely no hierarchy to those 3 groups at all. It was just trying to place staff in the best possible place to then obviously get best patient outcomes. And then how we've worked is that that was all on paper. So then to create groups on the shop floor, if you like, we've then created pods or smaller groups of staff, which then the numbers and the size of those groups reflect the clinical need. So we have a couple of groups for critical care, a couple of groups for medicine, and then more groups for rehab. And the reason having 2 of the same, if you like, is then from a COVID perspective, halfway through the week, we're able to rotate those staff, just thinking about reducing viral load exposure, so on and so forth. So we're trying to keep staff well, so they're not only kind of skilled and capable of seeing the patients that day, but also the next day and the next week, so on and so forth. That's quite important. And then when we're reviewing the pods, we are always kind of highlighting who's next to potentially move, whether we're surging again or whether we're de-escalating. So I think by categorizing our staff, it's given us a tool in a way that's going to have longevity, so we can use it during this surge, which has definitely worked, but then we're already using it now as we're starting to de-escalate, and then if we resurge, the work's already there to kind of automatically refer back to. So I'm hoping that one larger job is going to see us out. So that's how we've kind of moved our staff around. A lot of our services are still running, so I think that we've had to be really quite mindful of that. It hasn't been a case of, right, everybody respiratory, let's move you all over, because you can't then have a postcode lottery of diagnosis of who's getting what treatment. So not everybody with respiratory skills has moved into, say, a critical care pod. We've really tried to make sure that all of our patient groups have got the equitable service.
Brilliant. That, I mean, again, this boils down to having this, to some degree, flexible workforce and people who are willing and engagement. And I think, as just, you know, as Eleanor said, we found as physiotherapists, and it's not just physios, it was a lot of other, you know, AHPs, but they were more than prepared to put themselves forward and say, this is what I can do, this is what I need to know, and this is what I really want to support you guys doing, you know, your work. So Eve, I'm going to come to you, because you were on the educational team at Nightingale London, and one of the things that probably any of the Nightingales, heaven forbid if they all have to open, is workforce is a massive challenge, because you have to find a workforce that doesn't exist, because the hospitals are so busy and they are overwhelmed. You cannot take the workforce from them. So do you want to talk to us a little bit about your experiences, particularly with the non-respiratory physios, and how you developed an educational program to help get them skilled in areas that were useful during the pandemic?
Yeah, thanks, Rach. So I think when the Nightingale was set up, it was obviously supposed to be a big critical care unit, but you can't have the traditional roles of the traditional critical care roles there, because we just didn't have the staff with the kind of background training and experience that were putting themselves forwards. So they had to kind of define different models of working and look at specific Nightingale roles, they were called. And what my role there was trying to look at how we matched the volunteers that were coming forward into those Nightingale roles, and how we developed what we focused on is trying to develop a curriculum to try and make sure that each person that was volunteering had the appropriate induction to then move into this Nightingale role, if that makes sense. So we had a lot of physiotherapists volunteer to work at Nightingale, and mostly they were musculoskeletal physios. I think there's around 200 on the books. Mostly they were musculoskeletal physios. They may have been in private practice, and obviously that kind of care had been paused during the COVID pandemic. And MSK physios have a whole host of skills that could be useful within a COVID pandemic. And so in particular, rehab skills, moving and handling skills, for example. So we needed to look at how we could utilize those skills as best as possible within the Nightingale setting. So some of those were streamed into skills-based roles. So it may have been potentially a proning team, as opposed to so you were focused on performing a skill, not necessarily being given a job title, if that makes sense. And some people were streamed into working in the kind of respiratory critical care side of things, managing the patient's chests. And then others were focusing more on the rehab side of things, so working in step down areas. I think what I learned from that whole experience was the value in skills-based rostering. So not necessarily saying, oh, we need to have X number of band 7s working. It's actually, we don't need to worry too much about the banding or the job title. We need to look at the skill. So we need X number of people with this skill. And I think that moving forward in healthcare, it's probably quite a sensible approach to take ongoing, to think about skills-based rostering, to think about surge of the generalists. So to keep those general skills and have a flexible workforce that are able to go and work in different specialties. The challenge of how that's delivered is something that probably needs to be thought about in higher education. But what was really useful was that we were able to develop this curriculum of training to enable us, should Nightingale reopen, to enable us to stream people through the best induction package to fulfil their Nightingale role.
No, that's excellent, Eve. Thank you. And I'm going to flip it to Emma, because I know I'm going off piste here a little bit, but I know, Emma, that you have had very similar experiences about talking about the skill set, and I want to move on to shift patterns and how, workforce models, how we use staff, and I'm going to come to Eleanor for that. But Emma, if you could just talk a little bit about building on Eve's experience there and how you used skills-based rostering for your trust.
So, I mean, in essence, it's kind of what I've already said. I think the teams, with the refreshing of skills, the theory stuff we very much directed to Eve's module, because it's done and dusted. I do not need to sit in the evening and reinvent the wheel. But for us, it was the practical skills, and initially we started doing that training just for the physios, because they were the ones who were going to be coming in, setting up the the vents, etc., tweaking with them, so on and so forth. But actually that escalated dramatically, and it ended up being training for nurses, for medics. And I think the team, I didn't do the training, the team did it. They've probably trained 350 plus staff in the trust, so that then has enabled, that knowledge base has then supported how we've split our staff as well, because the responsibility isn't only on us. So again, it's a massive MDT approach. So it's looking at who has attended what training, where they are best suited to, where they are also comfortable working. If we were moving people who are currently in a rehab, yes, on paper I think they've got skills to work on crit care because they're on the on-call rota, so on and so forth, but some of them were still really quite new. If they then look like a rabbit in headlights and I'm going to totally freak them out, to me that's not somebody I'm going to move into a crit care pod. And we did do that. We kind of went with what they felt comfortable with as well, because as much as I'm there to support staff, I can't be there every morning at 3 o'clock. And that was really important, because again, I think the impact of this pandemic on staff is going to be massive. And I think at the minute we still have quite a lot of adrenaline running. It's still very exciting, and there's a lot of change to keep up with. So you're almost just in the momentum of COVID. So yes, it is looking at the skills, it's looking at the clinical areas that they're used to working in, it's listening to what the individual thoughts are as well. And that's how we've based our decisions on how I explained the pods earlier.
Thanks, Emma. Eleanor, I can see you have eager at the bit there. You have a point to make.
Yeah, so we developed a self-assessment tool. So anyone who hadn't worked in respiratory for a while, or had maybe come off our on-call and weekend rotas within 2 years, we sent them a tool that they identified the skills that they needed refreshing on. So that's how it was coordinated, and therefore that's how we could manage the training. So we identified groups of people that could be trained together according to what skills they need refreshing in. And some of our staff who were vulnerable or pregnant or asthmatics, they coordinated a lot of that education, and we did direct them to a lot of the online tools that were being developed as well.
Yeah, and I think that's a great point you've made, Eleanor, about self-assessment. And I know that happened across professions, so that happened across medicine, across nursing, across support staff. Do you have respiratory skills, do you have trachea skills, do you have moving and handling skills? And that's how a lot of trusts help to identify their workforce. So Eleanor, if I can stay with you for this next section. So we have this workforce, we've identified the workforce, we're respiratory specialists, if you like, those very confident in ICU. We'll have maybe support teams that are coming into the ICU for either rehab proning or maybe who don't have the confidence that maybe your senior respiratory staff have. Then you have those ward-based physios, and then you have kind of, like we said, this potentially, I don't want to keep just saying MSK physios, but physios who have been out of the kind of acute clinical picture for some time, but have actually been moved back in to support teams. And actually what a lot of teams found is that the MSK physios and maybe the orthopedic physios were coming in and supporting maybe the stroke wards, the green wards, so the non-COVID wards, to help maintain some level of therapy to those patients who were, you know, as equally important in this pandemic. We still had where usual trauma patients that were coming through, where neurology patients. So that's really important to remember and recognise. It's also important to recognise that we had to very much quickly change our 9 till 5 work. And now respiratory physios have always worked 24 hours a day, 365 days a year. I mean, this is our bread and butter. But we knew the demand on critical care and acute respiratory services was going to be so significant. We needed to know what we could contribute. And I know a number of trusts across the country, my own included, where we moved to a night shift pattern, where we identified very quickly we needed to support the patients 24 hours a day. Some trusts done things differently by providing an enhanced, say, twilight service. So they provided the same number of respiratory physios and rehab physios up until 10, 11 o'clock at night, because patients do have to sleep. And some have had an enhanced on-call model where they maybe doubled or trebled the number of physios that were on call during the evening, and thought about their compensatory rest the next day, because we'll have to look after our staff, don't we? So Eleanor, can you talk a little bit about your experiences and how, as a leader of services, how you manage that?
Yeah, so again, like Emma, we went to the blank piece of paper, and this was really handed over, I suppose, to our Respiratory 7 team, and they sort of were able to, you know, show to managers what their vision was quite quickly. So as you said, our traditional shift patterns didn't meet these patients' needs. They needed us, you know, for extended days. Often with treating these patients, we recognised that they needed shorter treatments, but regular. So, you know, spaced a bit better throughout the day. We were also aware of things like, you know, staff becoming very tired working in PPE, viral load, you know, and just the sort of the longer treatments that were required for these patients, you know, working with the multi-professional team, donning and doffing, you know, having to, you know, the patients weren't just, you know, really quick and easy to manage. So what we did is we sort of abandoned our traditional way of working, and we developed our 7-day working shift pattern. So we could cover the wards from medical respiratory wards and our critical care areas where we had the majority of COVID patients, to cover from 7:30 in the morning till 10 o'clock at night. So people would work these shift patterns. We looked at skill mix, we looked at, you know, shift patterns extending the day, people working, you know, 12 hours, and we were able to cover the service in those hours. And also then have 2 people on call at each site overnight. So this was on our Queen's site, and at the City Hospital we increased from 1 person on each site on call overnight to 2 people, mainly because, you know, we didn't know the demand on the service, but also we were mindful of what if somebody, you know, developed COVID symptoms themselves at night, and there was, you know, and they had to hand over, you know, to another person. So we extended our days, and, you know, we had some amazing feedback. You know, we had people on the motormed at 9 o'clock at night. And, you know, the sort of the staff on the unit just thought, you know, it was amazing, and it just made us be able to spread those treatments out little and often, and the staff, they just, that pattern of working, it was totally different, but everyone embraced it.
Emma, I know that that you had similar experience in your trust, and as Eleanor said, modifying those shift patterns. Do you want to talk a little bit about what you done?
Yeah, so ours is similar but also a little bit different. So in the daytime, we've actually managed to stick with our kind of 8:30, 4:30 or 8:35, which has worked quite well, and we were mindful. We were almost trying not to go to a 12-hour shift pattern just for staff well-being, if you like. What did change was the on-call setup. So traditionally, 7s and 8s don't do on-call, which is a whole separate conversation, but that's just how it is. But we did during this, and we acted as the second. We had our own little rota, and we acted as the second person on call. And this was great because it gave support for those lesser experienced staff members who, in essence, we're then going to see the sickest patients. And I think the additional skill set was really useful. But it also provided support to the wards which weren't traditionally respiratory wards, which I think is quite an important thing to remember. Maybe I should have mentioned that earlier, sorry. So one of our main, obviously critical care is still critical care, but our high care area is on a ward which is normally an older person's ward. So the nursing skill set is really quite different. So with the on-call people, yes, we're on call from 4:30 in the afternoon through till 8:30 in the morning. But we would automatically come in each night, and we're still doing this now, to the kind of 7:30 in the evening safety brief. And then that gives us an opportunity to further review some of those patients as well, which has been really, really useful. I guess in a way they're kind of pre-arranged call outs, but we were also creating our own caseload by going to check that patients were doing okay, rehab had gone okay, etc. So that was great from a team morale perspective as well, from like the MDT team. So that's what's happened in practice. In the background, we do have 7-day rotas written. We have thresholds written as to when we will shift to a 7-day working pattern. We already do 6 days is our normal anyway. And we also have a threshold of when the on-call service would become an actual shift, depending on the hours spent out and how many call outs and stuff. So that is all in the background, totally ready to go. So if our numbers suddenly increase, the work's done. And then same, I think Eleanor's already mentioned this, we have used different staff members as well to maintain our other services. So there are still, yes, outpatients has stopped, but our home NIV service, our CF service, is still working, but very virtually. So they are also in the background having their own service. So that's, some people have come off on-call rotas to keep almost those outpatient services 100% clean. But the rest of it, we've all bunched in together, and it's worked really, really well.
Yeah, I think you've raised a good point there about the red and the kind of green teams. So there's a number of trusts up and down the country that have very vulnerable groups, whether it be in home ventilation, whether it be in cystic fibrosis, and whether it be in the transplant patients. And it's important to note that the non-COVID facing activity is absolutely vital to continue. And I know some of my respiratory teams that are doing completely remote working, like you said, to prevent hospital admissions, to prevent exacerbations, and even, prevent death is really important and important to recognise. Eleanor, did you have a point on that subject?
Yeah, so I was just going to say that, just adding on to the information about our 7-day, our shift pattern changes, we did run this at a weekend as well, and it has worked well and give us a real sort of insight into what we could do at weekends should we ever get the funding to do a 7-day service. And yeah, we did have for our CF service, obviously the CF patients were very concerned about physiotherapists and all staff seeing them if they'd had exposure to other COVID patients. So we redeployed one of our MSK staff who was working in our staff outpatient clinic who had done a rotation in CF, and she joined the band 7 CF in that service to deliver that service, so that, you know, they knew that it was a totally clean service.
Thank you. So it's great to hear these lived experiences and how we've started at the very beginning, from education, from training, to deliver that through to skills-based training, to providing a workforce to meet the demand. And I think every one of us either works in a team, knows of teams who have not went above and beyond, because we don't like that term, but stood up to meet the demand that's being placed on respiratory services, not just critical care, as you say, Emma, across the whole respiratory spectrum. Now, as amazing as this is, as amazing as the media footage is, and the media attention we're getting at the moment in terms of respiratory physiotherapy and respiratory allied health professionals, it's slightly frustrating, because for at least the last 10-20 years, we've been trying to showcase our value. We've been trying to showcase the unique skills that we have and our contribution to respiratory medicine and critical care. And we have nice guidelines that were developed many years ago that have never been fully endorsed. And we've got a whole podcast on the rehab side of things. But in terms of creating this workforce and meeting the demand, there's certainly come with some challenges. And I just want to move on to how individually, what challenges you faced within the specific area of contribution you've had to COVID-19 from 2 months ago, and then we can move on to some of the successes that we've seen. So Eve, I'll start with you in terms of the challenges that you've seen, you know, across any of the work streams that you've been involved in.
So I think there's certainly been a lot of challenges from my with my academic lecturer head on. There's been a lot of challenges in terms of student placements. Continuing to deliver the course at the moment is absolutely essential, because the students are our future workforce, but having to deliver that in a remote way has been challenging, particularly for exams that normally would be Viva based, that especially things like musculoskeletal exams where you have to be able to demonstrate a skill. So we've had to adapt the educational model significantly to remote delivery of education for not just for the COVID course that we've developed, but for the whole bachelor's course and the pre-reg course in physiotherapy as well. So that has been a challenge. One of the other challenges with the students is clinical placements. So trying to get students the clinical hours that they need in order to qualify as physiotherapists has been difficult, and this challenge has been met differently at different universities depending on the structure of the course somewhat. So our course at Brunel, they have clinical placements at the end of the course. So there was a temporary register for students to register onto, but they had to have completed a certain amount of clinical hours in order to do that, which our students hadn't on the whole because of the structure of the course, but with the placements at the end. So the placement team have been working really hard with Health Education England in different models to try and address that. So one of the big barriers for that actually has been PPE. So the clinical teams are saying we'd have the students, but we don't have enough PPE for them. So they can't go on placement there. Another challenge has been associated with the death in service tariff. So if, as you know, if an employee dies in service, they get a £60,000 compensation to the family. This didn't apply to students. So there's been some work looking at how at trust having to employ a student for their clinical placement in order for them to qualify for this death in service payout should anything awful happen. So that's been another challenge as well. So a lot of the students are doing like band 3 or band 4 jobs in order to bulk up their clinical hours and to have a contract with the trust. We have moved away from the clinical educators doing the assessment. So the student would say have a band 4 job, go and work there for 2 to 3 months, and then they'll have a Viva with an academic, and that will then sign them off as having the clinical hours. So I think from that perspective, it's been really, really difficult. And it's absolutely paramount that we get these students through the placements and through their courses, because in 2-3 years we're not going to have any graduating staff, and we're in a situation now where we're looking at vastly increasing the number of critical care beds, and that means vastly increasing the number of critical care trained physios. So we need those graduates.
Yeah, I think that's a great point, and you've just raised the point that we haven't mentioned in terms of workforce and as managers, and that's the returners. So those returners that could come back onto the HCPC register as an emergency register. You know, if you've been on the register 3 years, within 3 years, you could reapply to come on. That has been an amazing workforce actually across the allied health professionals, and it's how we then use the education and training and the skills, everything you guys have just said. And I know a number of trusts, maybe smaller trusts, have really depended on the returners. So just want to say a massive shout out to those coming back into practice as well, because they're not just people who've retired, they're people who have maybe changed careers completely. So yeah, and great work behind the scenes, like you said, from Health Education England to the HCPC and all of the professional bodies as well, including the CSP for that work. So Eleanor, I'm going to move on to you, please, with some of your challenges and maybe how you've met the challenges and some of the successes that have come out.
Yeah, so I think a lot of what the challenge have been sort of practical issues, at a day-to-day level in running this new 7-day service with the different shift patterns. So I would say that communication has been challenging at times, so knowing when people are in, knowing sort of who's working that day, being able to pass on information. So we've used systems particularly for communicating about patients in putting a high, low, medium category on them, so we know which patients on a day-to-day level need to be seen first, and those that can wait for the the later shift workers coming in. I think just getting equity of service, so we making sure that we're delivering equity to our patients. We have like 2 sites of work. I think we've had to really upskill some of our sort of virtual learning, like having meetings on Teams and through Zoom and things like that, where we've not been used to using that technology to communicate before. The speed of change has just been absolutely overwhelming. I mean, I can remember in March just feeling like I just had so much in my head, and things were changing so rapidly, infection control procedures, availability of PPE in certain areas, what we were going to be wearing, it just seemed to be changing every half day. And I think there has been challenges in optimizing everybody's skill. Everybody has wanted to contribute, and recognizing what their skills are and thinking about where they're going to be best working. I think we're going to talk about it in a moment, but I think all the de-escalation is going to be sort of our next problem, and how do we go back to what we were doing before, and maybe that all that has changed, we don't know yet. And I think, again, for our people who couldn't work clinically, identifying roles that were really purposeful for them, like organising training, doing some of the admin work that they wouldn't normally do. So, there was a lot of, sort of we needed to identify roles for them quickly, so they weren't, just at home, not having, being well, but not being able to contribute and do things when they knew that we were all really, overloaded with work. And relaxation has been a real challenge, like being able to come home and not think about work, I think has been a challenge for a lot of, you know, people who are leading services and who are, you know, constantly thinking about how can we work differently and how can we work better, you know, and what's it going to look like in the future.
Absolutely, excellent. And Emma, moving on to you.
I think our challenges are quite similar to Eleanor, to be honest. I think a lot of it boils down to communication. So you've got teams who are newly formed. So you might have a pod like we have, but with 3 band 7s in. They're used to being a band 7 in their own right for their own team. And now all of a sudden they're kind of sharing a team lead role, if you like. That's challenging. Lots of different personalities coming together, and then working on wards that they're not used to working with an MDT that they're also not used to working with, from individuals not working with those professions. But again, same with Eleanor, people changed and just adapted to it as if it was absolutely, you know, no big deal at all, which is absolutely amazing. And I think the clinicians that I work with just have done such an amazing job. And I don't think we really could have asked for that much more from them at all. And as Eleanor said, I think one of my main worries is just making sure everybody is okay, because everybody's like, yeah, it's fine, this is lovely, but almost making sure that they don't feel guilty when they're coming into the office. And yes, they might have 10 minutes longer for lunch. I'm really not that bothered. They need the time out, and to make sure that at lunchtime, you know, you're trying to create an environment that's in essence an office, but enables them to have a non-COVID conversation. You know, that's so important. So I think the office space for us, well, for me, I think has been challenging, because obviously you have to enforce social distancing. There's no doubt about that. But then you're moving teams. So those handovers, those corridor conversations don't happen. And actually quite often they're really, really valuable. So it's making sure that people are up to date with what's going on, but trying to keep it personal. So it's not just email after email after email, trying to do as much virtual face-to-face, if you like, as possible. And again, not forgetting that we have got a workforce who aren't in the hospital. So we have quite a few vulnerable clinicians, pregnant clinicians, who are doing amazing jobs at making a baby, but are also doing amazing jobs of running services. So like our home ventilation service is a key example, and making sure that we are touching base with them regularly, that like Eleanor said, doing a valued job, but making sure that we know that they are equally as important, just because we can't, you know, even when we can't see them. So it's, yeah, there's loads of stuff that's been a challenge, but actually I would say that, well, I don't think I've got one thing that's a negative. I think all of them have turned into successes, for sure.
Thanks, Emma. So I'm cautious of time here, and I do really want to give everyone the opportunity to say anything else that we've missed, but also how on earth we are going to prepare for this next stage of this whole workforce we've now created and skilled, and then moving them back slowly into their existing roles, but also preparing in the back of our mind for a potential resurge. And this is if the nation is divided, the scientists are working so hard. The government, to some degree, are advising based on scientific knowledge we just don't have yet. So we are all, as clinicians, I think it's fair to say, expecting a second surge, or as lockdown starts to ease, an influx of patients again, maybe to the same degree, maybe to worse degree, we don't know. So how are we planning for research? Eve, if I can start with you, in terms of, from what advice do you have for people listening or watching in terms of how we can continue to prepare educationally?
I think there's a risk we might be in the eye of the storm at the moment, and things might start to, as you say, have a second surge and potentially be worse than the first surge. I think for that reason, it's really important that we there's probably a desire to relax at this point, but actually we need to keep things ticking over. So in terms of our delivery of our course, that's going to continue to try to keep training people so that they are in that, have that ability to work more flexibly across across different specialist areas. What's also really important, I think, moving forward is that we learn from the lessons of different centres. So I know that a lot of networks are getting together and looking at how different hospitals have responded to the surge and how the things that worked and the things that didn't work, and keeping those discussions and those communications going is really important, because we had to learn quickly about how to suddenly cope with such a higher demand, and so trying to discuss those, work out what worked at different centres, and come up with a plan going forward and how to cope with the research is really, really important. And again, I go back to this idea of skills-based rostering. I think we have got within physiotherapy a whole host of physios specialising in all kinds of different areas, but there are transferable skills, and there are skills that can be utilised well in a critical care or other ward areas. So thinking more about, okay, when this surge happens again, how can we place these people best in terms of managing the needs of the patient based on the skill of the clinician, not just based on their job role or title.
Thanks, that's great. And Eleanor, moving on to you.
So at the moment we're working really on sort of by a 2-week basis. So we've just got our rotas planned for the next 2 weeks. There hasn't been much talk of our redeployed staff going back anytime immediately. We're not really sure when that's going to happen, hence why we're working on a sort of 2-week system really. And that's working, with people sort of self-rostering, and then it being, the skill mix being looked at. We have de-escalated our second on-call already. That was one of the things that wasn't really needed. So that has been de-escalating, and will be de-escalated in the short term at the moment. But yeah, we haven't sort of got any sort of main indication of when there is going to be a change in the de-escalation, but I'm sure those conversations will be starting soon. We have got things like forms that we complete about services that have been postponed, stopped during sort of COVID, things like rehab classes that, our cardiac rehab classes, those sorts of bone marrow transplant classes, etc. So we are starting to look at when and how other services might recommence.
Great, that's fantastic, thank you. And Emma, moving over to you.
I think the research does make me a little bit nervous, if I'm totally honest. We have started to de-escalate to some extent. Same as Eleanor, our second on-call has stopped, but under very much knowing that it will restart at a minor notice if needed, but everybody was fully on board with that. So some of our outpatient services are being planned to restart. But when I say that, it's a very gradual restart. So it's the highest risk outpatient areas. So again, this comes down to, say, for example, our home NIV team. So there has been no face-to-face at all, but there are still some patients that need emergency setups, for example. So they are now starting to be done again, but with very strict criteria and processes to enable us to do that safely for staff and obviously more importantly for patients. Well, equally importantly, really. So staff are starting to move again. But like I say, we've got our structure of what's, the skills that these staff have. So at any moment, if the clinical demand changes, then we can just start jiggling staff around. I think my worry is about that almost wards that have been shut are reopening. And obviously, as much as they're, say, for example, a clean ward, if you like, non-COVID area, patients are coming in sick from the community with whatever they come in for, but they may also bring COVID with them. So then very quickly you've got a COVID area. So I think we're going to have a COVID population, because that's not going to go away for some time. But then I think that it will happen in-house as much as staff are doing an amazing job from an infection control perspective. It's almost that's going to contribute towards the second surge. So it's how we manage that I still haven't quite got my head round, if I'm honest.
No, that's great, thanks. So just to there's been some amazing discussion. Thanks everyone for your time today. Just to try and pull some things from a management and a leader's perspective here. It's to be mindful of your vulnerable staff, those staff that have been shielded, that might be working in roles they've never worked in, more administrative. They've definitely been as beneficial as those frontline clinical workers, and we need to make sure that we give them that feedback and congratulate them. We need to understand if staff are burnt out, how they're really feeling, that through feedback. We've got a whole session on psychology, and maybe how you get that information from your staff. And thank the returners, thank all of the other support staff that have come that allow us to do our jobs and meet the capacity. And also about how, like Eve said, we share this across the networks and we share each other's experiences, challenges and successes, because we certainly have not got everything right here. And if we are going to potentially go through a pandemic even now in the future, we need to plan and we need to understand. But loads of positives that have come out of this, loads of working together. There's natural leaders that have emerged throughout this pandemic, more so than ever, and it's about us as the managers saying, you're okay to do that, crack on, come and tell me if there's a problem. And that's really empowering leadership, and so I'm grateful to you all. So thanks again for your time. It's been lovely speaking to you.